Uh, Good evening, sir. Uh, my patient, 33-year-old female, resident of Jhansi, Uttar Pradesh, and educated up to higher secondary and housewife by occupation. And she was admitted with history of lower segment cesarean section that was done 20th of November 2021 at her native place. And she presented with complaints of cough for past 3 days and having the history of shortness of breath for past 3 days, as well as decreased urine output for 3 days. And also he was having the low grade fever for 1 day. I would like to start my history with her antenatal course. Uh, she's a mm, she's a 33-year young, married 2 year back, and marriage was non-consanguineous, and she conceived about 9 months back by the spontaneous conception. Her last menstrual period was on 5th of February, and the expected date of delivery was 12th of November. She was having no prior history of abortions or miscarriages. She was on regular follow-up with her gynecologist, and she received iron as well as multivitamin supplementation during the antenatal course. She remembered that around fifth month of pregnancy, she was told that she had some urine infections for which she received oral antibiotics for about 1 week. But that time she did not had any history of fever, dysuria, or burning micturition. Apart from this, her antenatal course was unremarkable. On direct questioning, she denies any history of deranged renal dysfunction or any other abnormalities in the blood reports. She felt quickening at around 6 months of pregnancy. She was admitted at her local place for delivery and underwent the lower segment cesarean section on 20 November 2021. The indication for the cesarean section was not known to the patient, and she denies any history of nausea, vomiting, headache, abdominal pain, or any history of raised blood pressures or any history of fetal distress. She was given 1 unit of packed RBCs was given after the lower segment cesarean section, but she denies any history of excessive bleeding per vaginum, any history of hypotension during this time. So post after delivery, after 2 days, she started to have cough that was non-productive in nature, that was insidious in onset, and gradually progressed in the over the next 2 days. Cough was associated with shortness of breath that was more in the lying down. Uh, Simultaneously, she also developed the low-grade fever that was for only for 1 day, and that was not associated with any chills, and that relieved with paracetamol. She denies any history of a hemoptysis, chest pain, or palpitations. She also noticed that decrease in output over the next 2 days. She was informed that she had some infection and kidney functions are deranged, for which she was referred here on post-op day 4. So in the negative history, she denies any history of nausea, vomiting, abdominal pain, headache, or seizure. There was no history of hematuria, flank pain, foul smelling discharge. She denies any history of NSAIDs, any alternative medications during the ANC course, and there was no history of any rash, joint pain, or photosensitivity. In the past medical history, there was no history of diabetes, hypertension, tuberculosis, or bronchial asthma, or any other significant medical illness in the past. In the personal history, her appetite and sleep was decreased for past 5 to 7 days, and the bowel were okay. And the family history was not significant. Both parents were non-hypertensive, non-diabetic. Yes, sir. So this was my history.
Was there any history of hypertension at 5 months when she had UTI?
No, sir. There was no history of any raised blood pressure during the even 9 month of course of pregnancy.
So there was no history of hypertension throughout the pregnancy?
Yes, sir.
And was there any history of antenatal discharge or hemorrhage?
No, sir. There was no history of any pervaginal discharge or any history of excessive vaginal bleeding was not also there.
So this was the first pregnancy, or there was?
This was the first pregnancy. She was married 2 years back, and about 15 months of marriage, he conceived by spontaneous conception.
And any history of swelling feet or face throughout the pregnancy?
No, during pregnancy, she not noticed. She has not noticed any history of swelling of the feet or any facial puffiness.
And you said that she developed cough and breathlessness.
Yes, sir.
That was after the cesarean section or before cesarean section?
Yes, sir. After the 2 days of the cesarean section, she developed the gradual onset of cough, and that was associated with shortness of breath. During her antenatal course, only at the month of 5 months, she was having history of this. She was told that she is having some urine infection, but that time also she was not having any history of dysuria, any fever, any flank pain. But she was given oral antibiotics for about 1 week by her gynecologist.
And was there any history of PNDs, paroxysmal nocturnal dyspnea?
So during the as the cough history of cough was only for 2 days, and during the night time she was having uh, the cough was more in the lying down position.
Any palpitation?
No history of any chest pain, any palpitation. That was not there.
Did she pass any urine after surgery?
Yes, sir. She was on Foley's catheterization after the delivery. So on the first day, she was having the urine output of 800 ml that decreased to the 400 ml after delivery. On third day, she was having the urine output of 400, and on the next subsequent day, she was having only urine output of 200 ml. So gradually over the 3 days, her urine output decreased.
So a patient after of cesarean section, suppose she passes urine after surgery, what one diagnosis is ruled out with this?
Any ureteric injury during the operation during the surgery?
Yes, actually, instead of injury, you should say uretary ligation. Sometimes, especially gynecologists, they inadvertently ligate the ureters, and sometimes patient develops anuria after cesarean section. So that is ruled out, that she passed urine after surgery.
Yes.
So what is your diagnosis on the basis of history? Provisional diagnosis.
So the provisional diagnosis is this is a post lower cesarean section patient post-op day 4, and likely possibility of acute kidney injury. The cause being the sepsis. The possibility of sepsis could be there.
Place of sepsis. Source of sepsis.
Likely as he underwent the cesarean section, so some chances of infections during the at the time of surgery or the possibility of puerperal sepsis could be there, but she was not having any history of foul smelling discharge, and also the history of the fever was only for 1 day. That was very mild fever, that up to only 100 degree, and was not having any history of any chills, was also not there.
Okay, are you sure that there was no history of any bleeding per vaginum, or because and secondly increased bleeding during cesarean section? Are you sure about it?
Yes, sir. I examined the patient on day 6 of. She admitted on day 4 of surgery here, and after 2 days, I examined the patient, and she denies any history of excessive bleeding per vaginum. She was using approximately 2 to 3 pads in a 24 hours time.
Her last menstrual period was on 5th of February.
5th of February, sir.
And the expected date of delivery was 12th November.
12th of November.
What was the reason why the cesarean section was delayed by around 8 days when the expected date was on 12th? It's a post-date pregnancy. So what all complications can you envisage in a post-date pregnancy?
As she was not having any labor pains, so the chances of the large for a date baby could be, so the abruptio placenta, the possibility of an oligohydramnios could be there.
What about the history of baby? What happened to the baby?
She delivered a baby of 3 kg, and she cries just after the delivery. and she passed the urine after 14 to 16 hours of delivery, and the stool was passed after the 1 day.
Okay, did you mention all
And
these
she was
things in history
feeding
regarding the birth history? Did you mention anything?
no, sir,
Make it
I
a point
forgot.
of mentioning it.
Yes, sir.
So your differential diagnosis is peripheral sepsis.
Yes, sir. But yes, sir, the possibility of peripheral sepsis is the
Okay.
first likely
What
possibility.
all other differential diagnoses can you plan in this?
As a case of postpartum and case of AKI, the second possibility could be the pregnancy associated thrombotic microangiopathy could be there.
Okay. And third possibility?
Uh, uh, Third possibility, although it's a very lower chances, or she was not having any history of any abdominal pain or nausea, vomiting. Still, there's the chances of the most common causes of AKI in pregnancy is the preeclampsia is a very common condition. So this could be
just
also in the lower
divert slightly away from pregnancy now. What are other causes of acute kidney injury? See, she is undergone lower section cesarean. Okay, lower segment cesarean section. Should have been given some antibiotics. Could it be acute interstitial nephritis, which has
yes, sir, the
presented as
possibility
low-grade fever, maybe some cough, maybe reduced urine output? Could it be?
Yes, sir.
So you have to
So
keep
the
your mind
possibility of
open.
AIN.
Okay.
Yes.
Yes, and any possibility of any cardiomyopathy, you know, which is happens around partum.
It's a postpartum cardiomyopathy. Postpartum cardiomyopathy.
What is actually the term? Is it postpartum or is something else?
No, sir. I had only the postpartum cardiomyopathy.
Peripartum cardiomyopathy.
Yes.
Have you heard of the term peripartum?
No, sir. I was aware of the postpartum cardiomyopathy.
No. Peripartum means that's why it what is the duration at what it starts and up to what time it ends? Because if the patient is having cough and breathlessness, you said, na?
Yes.
Yes, sir.
So you have to keep your mind open. Keep all the possibilities. As Dr. Manu Dodra said, just don't focus only on pregnancy. You could be having, patient may have been given some NSAID and Voviran. Patient may be having given some gentamicin. You don't know. So there can be other causes of AKI also. Interstitial nephritis can be there. Similarly, cardiomyopathy can be there. So peripartum cardiomyopathy starts usually 1 month before, usually in the 9th month actually. And it can stand up to 6 weeks after delivery. And patient can have, what is the incidence of peripartum cardiomyopathy?
It's about one case in about 1,500 of deliveries.
No, you
one case in.
You're not ready. You mentioned something about this TTP. Is it actually TTP is more common or HUS is more common or HELP syndrome is more common?
The HELP syndrome is more common.
Yes. So HELP syndrome is more common.
Yes, sir.
And why this patient was given blood transfusion?
She was not
if there
having
was no bleeding. If there was no bleeding, why is anybody will give blood transfusion?
She was having this shortness of breath, and she was told that she was having the hemoglobin is on the lower side, for which 1 unit blood transfusion was given. Although there was no history of any postpartum.
This is after the surgery or during the surgery or before surgery?
Or before the surgery, yes.
This is after the cesarean section, day 2.
Okay.
So that
when she started to have some shortness of breath was there, then her CBC, she was told that she was having the low hemoglobin. So for that, she received the 1 unit of PRVC at their native place.
Could it be bilateral renal vein stenosis, renal vein thrombosis, pelvic thrombophlebitis, post-cesarean pelvic thrombophlebitis, and subsequently she develops renal vein thrombosis? Could it be like that?
Yes, and shortness of breath could be due to pulmonary embolism. You have to take the
But
it's a bilateral renal vein thrombosis. The patient should have the abdominal pain or flank pain should be there. There's
not necessarily. They might not present with anything. They might just present with hematuria.
Also, she was not having any history of hematuria. Was also not there.
Now urine output had dropped. Okay.
Yes.
Think out of the box. Pelvic
Yeah.
thrombophlebitis is quite common.
You should keep all the possibilities. Na? So pelvic thrombosis is a common patient is immobilized, and in a pregnant patient, this pelvic thrombosis is a possibility. Hematuria may or may not be there. So what is your provisional diagnosis now? Before we proceed further.
1, 2, 3, 4.
Yes, sir. The provisional diagnosis, it's a acute kidney injury, postpartum acute kidney injury. The possibility of first possibility is the sepsis. Second possibility could be the possibility of
either you say peripheral sepsis,
yes, sir,
or you say UTI, or you say chest infection or bronchopneumonia. So what do you think it is?
It's a likely possibility of peripheral sepsis.
So peripheral sepsis.
Yeah,
so then you have to be specific, na?
Mm.
That's why Dr. Manu Dora asked you what sepsis. So there was nothing to suggest UTI, but still patient can have UTI. Tough fever and breathlessness, patient can have bronchopneumonia. And you feel that there could be septicemia also?
Yes, sir.
Was there any shock at any time, hypotension?
She was not given any history of any low blood pressure. She was not aware of that.
And will you keep the possibility of HUS TTP?
Yes, sir. The possibility of HUS TTP could be, this is a case of postpartum. So chances of the renal involvement in case of at the presentation of the HUS TTP is more in the postpartum period. So possibility could be
so
there.
Dr. Dora, I think we should proceed further.
Proceed, yes, sir. We should proceed.
Okay, general physical examination.
So she was conscious, oriented to the time-placed person, and her height is 160 centimeters and weight is 62, and BMI is 24 kilogram per meter square, and decubitus is sitting. On general examination, she was having the pallor, that is 1+, icterus is present, and there is no clubbing, cyanosis, and edema of the feet is present, that is up to the ankle joints, and GBP was not raised. Her pulse was 90 per minute, that is regular, normovolumic, no radioradial or radiofemoral delay was there, and conditions of the vessel wall was not thickened. Blood pressure in the right upper limb, it was 126/80, and in the left upper limb, it's a 134/80, and both lower limbs, the blood pressure was 140/86. The respiratory rate is 24 per minute. This is thoraco-abdominal, and no accessory muscles of respiration were obviously not were in use. And she was having the oxygen saturation of 92 to 93% on room air. In the para-abdominal examination on inspection,
her physical examination is not complete, sir. We are dealing with a case of acute kidney injury. What are the other general physical examination you are going to look for, rather than coming on a suspect examination?
So she was not having any obvious rashes over the feet, edema that were present only up to the ankle joint. The edema was present.
And Balla sir had talked about something about pulmonary thromboembolism. So we're going to look for some signs which can give you a hint towards pulmonary thromboembolism. Calf muscles, thigh muscles, tenderness, swelling.
Yes, sir.
Yes?
Yes, sir.
Okay. And
sir, I have not examined for that. Yes, I forgot.
Okay. Yes, and rashes ho gaya. What about joints?
The joints were no obvious swelling or any
photosensitivity rash?
No, sir.
No malar rash?
No, sir.
Oral ulcers?
No, sir.
It could be quite be a case of connective tissue disorder.
Yes, sir.
Okay. Anything else in general physical examination you would like to see?
No, sir.
Any ecchymosis in the periphery, abdomen, flanks? Could there be a case of pancreatitis?
Right.
Which is presented with severe sepsis.
Yes, sir.
है ना? चलो आगे.
So in the parabdominal examination on inspection, the umbilicus was transversely stretched and the striae were present, and she was having the stitches were present on the lower segment of the abdomen, and no obvious hernial orifice were seen. On palpation, she was having the abdomen was soft and
How was the
non-tender.
scar?
It
Abdominal
was
scar?
transverse. That was transverse scar in the lower segment of about 10 to 12 centimeters.
Pen and steel. Pen and steel
Centimeters.
incision. ठीक है?
Yes, sir.
चलो आगे.
So on palpation, the parabdomen was soft and the non-tender, and uterus was palpated, that is 4 centimeter above the pubic symphysis, and on liver and spleen were not palpable. On percussion, the tympanic, the abdomen was tympanic and no shifting dullness was there. On auscultation, the bowel sounds was heard, that is 6 to 8 per minute.
Any bruise? Uterine
No, sir.
artery or maybe any AV fistula formation? No.
No, sir.
Was the uterus tender?
No, sir. Uteral tenderness, parabdomen was not tender, and uterus on feel soft and non-tender.
Okay. ठीक है. आगे.
In the chest, she was having the engorged bilateral engorged veins over the chest on inspection. This was the bilateral symmetrical chest with no obvious deformity. On palpation,
Where were the engorged veins?
over the breast area.
You examined the breast area?
No, sir. My fellow, the gynec fellow, she examined.
No, why you particularly wanted to see the breast area?
Over the front of chest, the neck veins were visible, but
why were these engorged veins?
because of that she was not lactating her baby here, the possibility of breast engorgement and that could be there.
Proceed further.
On inspection, it's a bilateral symmetrical and no obvious deformity. On palpation, the bilateral chest expansion was 4 centimeter. That is equal on both sides, and tympanic not heard on percussion. On auscultation, she was having the bilateral vesicular breath sounds in the supra and interscapular area, and bilateral clefts were present in the infrascapular area. In the CVS examination, apex was not visualized, and on auscultation, she was having the heart sounds were S1, S2 were heard and having the no murmur. In the CNS examination, she was having she was conscious oriented and higher motor mental functions were normal, and no sensory motor obvious deficit was there, no localizing signs, and the people were reacting to the light, and plantars were flexor, and the clonus were absent. Clonus was absent.
You said there were bilateral crepitations?
In the infrascapular area, there was crepitations were present.
Basal crepitations were there or only infrascapular?
No, it's a basal crepitations.
And you said that neck veins are not visible, JVP is not raised.
I examined the patient in the sitting position, so the possibility of that JVP may not be assessed, may not be.
At what position you look for JVP?
For JVP, we examined the position at 45 degree position from the horizontal.
So you examined in that position?
Yes, sir. For JVP, I examined that in the 45 degree reclined position, but that way JVP was not visualized.
You said
not raised.
No edema also?
Edema was present, that was up to the ankle were present.
So, I mean, actually, what I want to know is whether the patient is in congestive heart failure or not. Liver, you said, is not palpable. Liver is
Yes,
not
sir.
palpable.
But she's got icterus.
Icterus was there, and liver is it's a not very, the margins was just felt margins. It's a the borderline, just I felt the liver, but I was not very
It is very,
sure
very
about the liver.
unlikely that in a pregnancy, and the liver is not palpable, and patient is having jaundice, patient is in congestive heart failure, patient is having cough, breathlessness, and your findings are contradictory actually.
Sir, liver was just I palpated. It's just palpable, but no, I was not able to appreciate any hepatic dullness below the costal margins.
So did you mention that there is jaundice?
Yes, sir. The pallor and icterus was present, and edema up to the ankle. These are present.
Any other finding you want to ask Dr. Manu Dora before we ask him final diagnosis?
Sir. We'll ask him final diagnosis, sir, because
Yes.
there's nothing in the examination, sir.
Please give your final diagnosis.
So I left with the urine routine.
Okay. You will like to do urine routine examination before. Okay, good.
Yes,
Very good.
So my urine dipstick showed the protein was 2+ and the glucose were absent. And the routine and microscopy showed it was dark yellow, pH of 6.0 and a specific gravity of 1.012. And the pus cells of 4 per hyphophore field and epithelial cells of 7. And RBCs were 4 RBCs, and there was no cast or no crystals were seen.
Patient is on catheter.
Yes, sir. Foley catheter was in situ.
Okay. So now what is your final diagnosis?
My final diagnosis is it's an acute kidney injury. The possible differentials could be first possible differential is pubertal sepsis. The second possibility of HELP syndrome, and the third possibility of thrombotic microangiopathy could also be there, and fourth possibility of acute interstitial nephritis. Yes, sir.
Please, Dr. Dora.
Approach. Now, how are you going to approach this case? You're given us 5 diagnoses, all different spectrums. One is HELP, other is TMA, third is sepsis, fourth is acute interstitial nephritis. So now tell us what all investigation are going to do and to whom on to the diagnosis. She's got icterus. My diagnosis towards HELP syndrome, like Dr. Bhalla said, it's quite obvious now. So you should be missing HELP. So how are you going to investigate the patient? You got 4 diagnoses: TMA, HUS, TTP हो गया, ठीक है, pregnancy induced TMA, other is HELP syndrome, puerperal sepsis. So how are you going to approach this case?
So first of all, the complete blood counts and the peripheral blood smear.
Aimed at?
Complete blood count,
what are you going to find
yes,
in different examples?
So in the complete blood count, I will, if it is a HELP syndrome, the possibility of the thrombocytopenia could be there. And
it could be there in thrombocytopenia, could be there in TMA also.
Yes, sir. TMA.
And
so the peripheral blood smear, if the peripheral blood smear, if the case of TMA, then possibility of the cystocytes could be there. Okay. And with the liver function test. And
अभी तो पहले आप hemogram पे हो.
Yes, sir.
So what are you going to see? You're going to see for hemoglobin?
Yes, sir.
He's already been given blood transfusion.
1 unit.
Okay. So kind of anemia you're going to see?
Yes, sir. Yes, sir.
Yes. Okay. Secondly, you're going to see platelet counts.
Yes, sir.
If what is the limit of platelet counts after which below which you say there's I suspect HELP syndrome or thrombotic microangiopathy?
It's for HELP syndrome, it's less than 1 lakh.
Okay. And for thrombotic microangiopathy?
It's less than 50,000.
कहाँ पढ़ा आपने? कहीं पढ़ा होगा? It's again 1 lakh.
Yes, sir.
ठीक है?
Yes, sir.
Okay. Second thing, you're going to
The
see for
WBC counts.
yes,
Yes,
and
sir. The differential counts.
yes.
Yes, if it's a case of peripheral sepsis, the chances of the total leukocyte counts as well as the polymorphs on the high side.
Okay. Peripheral smear. What will you see?
In the peripheral smear,
Schistocytes?
the spherocytes as well as the cystocytes and any fragmented RBCs and the target cells could also be there in case of liver involvement, the HELP syndrome. And, the giant platelets, I'm not very aware.
What about the left shift? Toxic granules and left shift.
Yes, sir. In case of sepsis, the shift is on the left side.
Okay, fine. So hemogram में fresh hemogram. Next.
Hemogram, peripheral smear, and after that the liver function test. Or before that, I would also want to know about the LDH.
Yes.
Hemolysis is ongoing. Hemolysis is there, then LDH would be on the higher side. And also the haptoglobin levels.
Okay.
If
if
haptoglobin level is less than 25, it's a more specific than the LDH levels. Haptoglobin less than 25 suggests the possibility of HELP syndrome. The hemolysis possibility is high. And then I would like to know about the liver function test also. So in the liver function test, if the jaundice, the bilirubin levels, the direct and the indirect, in case of hemolysis, there the chances of indirect bilirubinemia will be there. And the liver enzymes, in the HELP syndrome, the liver enzymes would be on more than 2 times of the normal limit, the SGOT, SGPT. And if there's any obstructive pathology, then the alkaline phosphatase would be on the higher side.
Yeah, we're talking about this case. You said AST, ALT should be more than 2 times the higher limit of normal. But in the presence of acute kidney injury, how do you interpret AST, ALT?
In AKI, the levels would be even or more higher side. The 2 times of the limit is in a patient without any renal involvement is 2 times is okay, but with renal involvement, the levels will be on more high side.
So suppose there is a renal involvement, what is the normal level of AST and ALT you take? What are the studies shown?
Sir, I don't know.
पढ़ोगे इसको?
Yes, sir.
ठीक है. Next meeting में बताओगे?
Yes.
ठीक है? Next.
After that, the kidney function test.
No, liver function test खत्म नहीं हुआ है अभी तक.
Yes, sir.
What all other components of liver function test are you going to see?
Total protein serum albumin. Yes.
Yes. What do you expect in serum albumin in this case?
Serum albumin, the chances is on the lower side. It's
Why?
Looking the liver involvement is there, and albumin is a acute phase reactant, negative acute phase reactant.
Very good.
It will go on the lower side.
Okay.
And also in the case of sepsis, the albumin will be on the lower side.
Okay. Next.
After that, the alkaline phosphatase.
Kidneys. No.
Yes, sir. So the kidney function test, the urea creatinine, as well as the uric acid and electrolyte, sodium, potassium, calcium.
इसके बाद और क्या करोगे?
In kidney function.
ना हो गया, kidney function हो गया. इसके बाद.
अच्छा.
Next.
The complement levels, the C3, C4, you can do.
Would you like to do an ultrasound first? Ultrasound of the kidneys.
Yes, sir.
For what?
To look for the any ultrasound kidney, to look for the kidney size, as well as the any obstruction in the drainage system, any bladder pathology, as well as any uterine intrauterine collection is there.
Retained products of conception.
Yes, sir.
And
the liver involvement could be there in case of she was having the jaundice. So the possibility of hepatomegaly could be there.
Okay. Next.
After that, the viral markers,
Hmm.
hepatitis B and C, and hepatitis A and E. So, although the possibility of A or E and also could be there, because in pregnancy the chances of hepatitis E is also quite high.
Okay. What next?
The coagulation profile and the complements C3 and C4. Yes.
Okay. So.
And you said that patient had 2+ proteinuria. What do you think is the cause of proteinuria?
The cause of proteinuria, it could be the glomerular or the tubular, but as the RBCs were nil, so the chances of the tubular proteinuria is high here.
No, you said no, there were 4 RBC.
Yes, sir. But for acute glomerulonephritis, the RBC limit is minimum 5 RBCs in the high power field.
So you mean to say that if it would have been 5, then you would have kept the possibility of acute glomerulonephritis? Any simple explanation for 2+ proteinuria in this patient?
Increase in the GFR, hyperfiltration.
Patient who is in ATI, do you think he is having increased GFR?
No, it's a hyperfiltration of proteins.
Sir has asked us a very simple question. A case of acute kidney injury, do you expect hyperfiltration?
No, sir. It could be possible because it could be the urine output slightly decreased over the 3 days. The urine was concentrated urine, so
somebody has given you. Somebody has prompted on the screen, and you have said the same thing.
And we are not satisfied with that answer.
What next?
I would also want to go for the urinary sodium.
Simple causes, which are
Pardon,
not
sir?
Very simple innocuous causes of proteinuria, not actually related to kidney disease. Have you heard of these causes of proteinuria?
No, sir. No, sir.
Not heard. Can fever cause proteinuria? Can exercise cause proteinuria?
Yes, sir.
Prolonged standing.
It's orthostatic.
What about some patient is on catheter? Can you have fast proteinuria?
Yes, sir.
How?
False proteinuria, if patient is having the pH is on the higher side, urine pH is more than 7.0. If a patient is having high protein diet, this can also lead to the false. Or patient is having very concentrated urine pH more than 7.0, and
okay, Dr. Dora asked you about ultrasound. So what do you expect in this patient on ultrasound?
Patient was having jaundice, so possibility of hepatomegaly could be there.
Or sometimes you can have fulminant hepatic failure, liver may be shrunken.
Yes, acute fatty liver of pregnancy. Yes, sir.
So that is not a rule that if jaundice is there, that means hepatomegaly has to be there. So other thing, what about kidneys? What do you expect in this patient as far as kidney is concerned?
It's a case of AKI, so
Okay.
so not sure.
You don't know the ultrasound findings. If I ask you that you give me the what will you expect in this patient on ultrasound? Then what
Normal size kidney.
you mean normal size kidneys?
Yes,
You
sir.
expect a normal size kidney in this patient? Just immediately after delivery.
In the pregnancy, there is some increased size.
Okay, now you tell me what are the physiological changes in pregnancy in kidneys?
So in physiological changes in kidney, there is increase in GFR of 50%, and there is renal plasma flow increased by 80%.
What anatomical changes occur in pregnancy?
Pardon, sir?
What anatomical changes occur in pregnancy in kidneys and urinary tract?
There is a dilatation of the the urinary calyceal system, and there is more on the right side. So there is slow drainage as well as the pelvis, urinary pelvis volume that also increases. So there is urinary stresses is there, and the kidney size increase by up to 1 centimeters.
So number one, you can have large size kidneys. Okay. So number two, you said there can be, actually you are not using the term, there can be hydronephrosis. And this hydronephrosis up to what is the extension of this dilated ureter? Is it the whole of the ureter is dilated, or there is some characteristic?
And the upper part, upper 2/3, the iliac vessels crosses the ureter, the above which there is dilatation of the ureters.
So why that there is a why narrowing is there at that point? What are the various causes of that?
Because of compression by the iliac vessels.
And hypertrophied broad ligament.
Yes.
So these changes will can persist. And what is the term duration of peripherum we take? Up to what time after delivery this changes will reverse? What is the duration of peripherum?
By 6 weeks.
6 weeks. Okay. So what is the definition of a PIH?
It's a pregnancy-induced hypertension. It's a the hypertension that is first time detected in the pregnancy, that is having the value of systolic blood pressure more than 140 and diastolic blood pressure more than 90.
At what time?
20th week of pregnancy.
More than 20 weeks.
So more than 20 weeks of pregnancy. But any biomarkers you know by which you can diagnose it before 20 weeks?
No.
Anybody?
Serum FLT,
anybody in the audience?
I think.
Okay, someone, Dr. Vivek has written
Yes.
SFLT1. What is SFLT1?
No, sir.
Sir, it is soluble FMS like tyrosine kinase 1.
Okay. But it is actually anti-VEGF.
Yes, sir.
What is a soluble endodrin? Soluble endodrin. You know, na, what happens? You have to go into the physiology. What happens to the uterus? How angiogenesis occurs, neoangiogenesis occurs, how the tissue fibrosis, tissue growth occurs. That's why there is a TGF factor. And then this soluble endodrin has effect on TGF. So these are the various changes. What happens to blood pressure in pregnancy?
Usually blood pressures in the first, it usually decline the systolic blood pressure about 20 and the diastolic blood pressure about 10.
Why?
Because of there is a decrease in the peripheral vascular resistance, there is a decline in the blood pressures.
Decrease in peripheral vascular resistance. Why?
Because of there is less renin sensitivity in the pregnancy.
Why?
Renin because of the at the receptor level there is decrease in sensitivity, although the renin renin and aldosterone system dependent increase in blood pressure is not there.
Why it is not there? Why this resistance to renin or angiotensin system vascular restriction is there? Why this vasoconstriction is there?
Because of the relaxin hormone as well as the
which hormone?
Relaxin and progesterone also.
Progesterone.
Up to some extent. Yes.
There are plenty of progesterone throughout the pregnancy. So it is the progesterone which is actually causing the resistance to the action of renin angiotensin. That's why there is no vasoconstriction. This resistance is lost in PIH. This resistance is lost in PIH. What happens to plasma volume in pregnancy?
So the plasma volume increase by about 50% increase in plasma volume is there.
And what happens in PIH? Most of the time when you have a patient of pregnancy induced hypertension, what if do they have excess volume, or they have the normal volume, or they have less volume?
Volume, I'm not sure.
So they actually have a contracted intravascular volume. They may have a lot of edema, anasarca, but the intravascular compartment is actually contracted. That's why, what does it have implication? Even if a patient have got massive anasarca, edema, or urea, the one thing which you should not give, what is that? One treatment which you will not give to this patient is, so you don't give diuretics to these patients, okay?
Yes.
If you want to give, you may give albumin, but you have to avoid diuretics. Yes, Dr. Dora, please.
Okay. What next? You've done all the investigations. What next?
If it is a case of
a urine output is totally stopped. You've done all the investigations. What investigation is left which is going to cleanse the diagnosis?
sir, can you repeat this question?
My question is, you have done all the investigations. Am I audible?
Where you have to find the diagnosis in the patient. So you have done all the investigations. So what will you do now to get the diagnosis?
For diagnosis, although the liver biopsy is not very commonly done.
We are talking about kidney. If you are talking about
biopsy,
kidney क्यों नहीं करोगे?
Liver biopsy क्यों करोगे तुम?
Bleed करेगी and then she'll go away.
नहीं, indication क्या है? What is the indication of doing kidney liver biopsy? You tell me. But don't give this kind of answer in the exam.
So you'll do kidney biopsy. Okay.
Yes, sir.
What do you expect in kidney biopsy? Give us the diagnosis now. What all things can you expect in a kidney biopsy? You had 4 differential diagnoses.
Yes, sir.
Okay.
So in kidney biopsy, in the tubular compartment, the possibility of endothelial disruption could be there. That could suggest the possibility of acute tubular necrosis. Or
in tubular compartment, endothelial dysfunction.
Yes,
tubular compartment में कौन सा endothelium है यार?
कैसे biopsy describe करते हो? do you describe biopsy start with the tubular department? What is department? That's how you describe a biopsy. Suppose kidney biopsy there. First you see that there will be a section on low power, H&E stain. Then there is a system to describe biopsy. How do you start biopsy description? You tell me.
Yes, sir. The how much is the core size
Okay.
on
Then
naked eye examination?
How many glomeruli are seen?
Yes, sir.
Then you first
The
describe
glomerular
glomeruli.
compartment.
Then you after glomeruli you go to this medulla. Then you go to tubules, interstitium. Then you go to vessels. What you are talking is totally different. Tubular department, and you said something right. Endo. What did he say, Dr. Dora?
Endothelial cell swelling in tubular department.
So please describe your biopsy.
You have biopsy report with you?
No, sir. This patient was not underwent the biopsy. She underwent 2 sessions of hemodialysis, and after that she started improving the kidney function. Her urine output improved over the next 3 days, and her peak creatinine reached up to 9. That gradually declined, and over the next 2 weeks she was having the good urine output, and renal function showed the improving creatinine. So she had the last creatinine value of about 2.5.
So ये तो आपने history में बताया नहीं कुछ भी. See, you have taken the case today. Your patient was admitted with you after LSCS. The patient was admitted with you a week back. Am I right?
No, sir.
So what was the course of disease? You did not tell us anything. What treatment was instituted, and what was the further course?
Sir,
we are thinking that we have seen the case today, and we are just evaluating.
You should give the total history, na? This all should have been given in the history. Then so, we will not discuss at all about acute cortical necrosis.
Yes, sir.
Yes.
So over the 2 weeks, I took the history at about 2 weeks back, and during the past 2 weeks, I just checked the reports back, and then see the kidney function resolve spontaneously with supportive treatment over the past 2 weeks. And she is currently off dialysis, and she required only 2 sessions of dialysis, and the AKI is in the resolving state. Yes, sir.
What do you think is the long-term outcome in this patient? Suppose creatinine comes down to 1.2 milligram%.
So the chances of the renal disease progression in the future is much higher as compared to the general population.
How much?
And further progression of ESRD in about 10 to 15% of the patient of in the long term, the chances of.
Any reference, any study? Can you quote any reference?
No, sir.
Then how are you making the statements? If you don't know such a heavy statement you are making, that this patient of creatinine 1 today with 10 to 15% chances are there, you should quote the reference also.
No.
Okay. So what are the stages of AKI?
The stages of AKI, according to the KDIGO guidelines, the 3 stages are there. In the stage 1, there is the increase in serum creatinine more than 0.3 or 1.5 to 1.9 from the baseline, having the urine output of less than 0.5 ml for more than 6 hours. And the stage 2 AKI, there is a increase in creatinine.
Stage 1 AKI is not complete as yet. Duration.
Sir. So within the increase in serum creatinine within 48 hours, it's a more than 0.3 increase, or over the past it's a within 48 hours, the creatinine increases more than 0.3 or 1.5 to 1.9 times from the baseline. And the urine output less than 0.5 ml per kg per hour for more than 6 to up to 6 to 12 hours. And in the stage 2, there is a increase in serum creatinine from 2.0 to 2.9, and the urine output 0.5 ml per hour for 12 to 24 hours. And in the stage 3, there serum creatinine 3 to more than 3 times of the upper limit of normal, and the urine output less than 0.3 ml per hour for 24 hours.
What are the other classifications you know?
The rifle criteria and the Aiken criteria.
So what is the latest now? What is the latest accepted?
The KDIGO.
Okay. What are the definitions, various definitions of ATI you know? What is the difference between ATI and ATD?
What is AKD?
AKD. AKD is the it's a
Tell us the full
renal
form
dysfunction
first.
history.
Tell us the full form of AKD.
Acute kidney disease.
Disease नहीं होता, disorder है.
Disorder, sorry.
ठीक है? Is AKI part of AKD?
AKD is a broad term that is having the involvement of the duration of AKD is up to 3 months, and more than 3 months it's a CKD, and up to the AKI is having the duration of the 1 week.
Anything to do with GFR in AKD?
Yes, sir, but I not remember.
ये bread and butter है. ये आना चाहिए. ये हमें बताने का जरूरत नहीं है. This you should be telling us. चलो. Had you done a kidney biopsy in this case, what would you have expected? भल्ला सर का क्वेश्चन मैं फिर से पुट अप कर रहा हूँ. What would you have expected in this case had you done a kidney biopsy on day 3 when her urine output dipped? Give us the scenarios. First is sepsis. Second is pregnancy-induced TMA. Third is acute kidney injury. Fourth is acute interstitial nephritis. What all features will you get in kidney biopsy? Bolo.
So in acute tubular necrosis, in sepsis, the possibility of acute tubular necrosis could be there. So in acute tubular necrosis, in the tubular compartment, the tubular epithelial cells dislodgement or disruption of the membrane tubular cells. In case of
anything you expect in this patient in glomeruli?
No, sir.
You had seen this patient since the starting. You have seen this patient. Can you tell us what was the platelet count in this patient?
70,000.
70,000. Okay. So tell us what are the features you find in thrombotic microangiopathy in a kidney biopsy. Mota features bata do. $70,000 platelets say. Was the patient in DIC that time?
There is no obvious bleeding signs was there, and no petechiae or no ecchymosis was there, and the fibrinogen level that was normal.
Okay, so what are the findings you will get in thrombotic angiopathy or kidney biopsy? जल्दी बता दे. 7:30 हो गए, जल्दी बताओ. नहीं पता. चलो ठीक है. My next question is, it's been almost 13 days since the time she went into acute kidney injury. Okay. Her creatinine is still 2.5. When are you going to plan the biopsy, if at all? Would you plan a biopsy or would you not?
It's a day 13.
It's day 13 today.
Yes.
So would you creatinine is still at 2.5? Although kidneys have opened up, would you still like to do a biopsy or no? If the creatinine does not settle by another maybe 3 or 4 days? If yes, then what is the reason? If no, what is the reason?
If there is no bleeding risk is there, definitely if creatinine is not settling down, we would like to go for kidney biopsy. That suppose if AIN is there, then we can go with steroid treatment. If suppose ATN is there, then there is no treatment is required, and the kidney will improve with time.
Sir?
But only one thing which I want to highlight at the end is that whenever such patients come to you with ATI, it is very important to look for retained products of conception. Number one, if it is abortion, some abortion done outside, but even in cesarean done outside, sometimes you get some retained placental products or some clots, and that is a cause of ATI in these patients. And if you don't clear the uterus of these products, you do a DNC, ask the gynecologist to see, and once you do this procedure, then definitely there is a rapid improvement in the patient's condition. So it is very important to look for retained products of placenta or clots or infected products. That is, I think, very important. So did you look for in this patient? Gynecologist consultant?
Yes, sir. Gynecologist look this patient, and on transvaginal sonography, there was no written product of conception was there.
Okay. So this patient has done that way well.
Yes, sir.
I think, Dr. Manu, over?
Sir? Yes, sir. It's over, sir.
Yes.
Sir.
Okay.
बिना किडनी बायोप्सी के मजा नहीं आता सर.
हाँ, बिल्कुल. हमारे पास नेफ्रोलॉजी में पेशेंट हो तो बायोप्सी हम कर ही देते हैं. चलो, I think you have to improve a lot.
Yes.
Dr. Anvesh?
Yes, sir.
Just whatever we have, please note it down, whatever both of us have told you, and read
Yes,
it
sir.
today only.
Yes,
okay?
Sir.
Right.
Yes, sir. Thank you, sir.
Thank you, sir.
Thank you, bhai.
Thank you, sir.
Thank you, sir.
Faculty.